So I had mentioned ataxic dysarthria, and here you see on this slide, what about ataxic dysarthria? Well, I mentioned that ataxic dysarthria is most frequently caused by damage to the cerebellum. And we know that the cerebellum helps maintain muscle tone, and it has a lot to do with coordination and balance. So it makes sense that if you have difficulty with coordination, it will affect your speech. The speech characteristics of ataxia really overlap a lot with those of apraxia. For example, in ataxic dysarthria, we see inaccurate movement. We see that in childhood apraxia. We hear inconsistent voicing errors due to mistiming. They often have imprecise articulatory contacts. One of the things, though, that we see in ataxic dysarthria that we don't see very often in childhood apraxia is incoordination of the respiratory stream. So when we're talking, we always take in air, reach a certain tidal volume, and then we let that air out over time as we execute continuous speech. For children, and adults for that matter, with ataxic dysarthria, some of those people might have trouble coordinating when they take a breath in, where they are in the breath stream when they begin to speak, etc. You don't see that very often in childhood apraxia, but you see it more often in ataxic dysarthria. Here are a few other ways where we can differentiate ataxic dysarthria from childhood apraxia. Well, inconsistency is seen in both. In CAS, though, these inconsistent errors are across movement types, across syllable shapes, across particular vowel content, whereas the inconsistency in ataxic dysarthria is more consistent across tasks. So in childhood apraxia, they may have less inconsistency if they are doing very simple programming requirements. For ataxic dysarthria, usually the children will be talking along more than maybe a child with severe apraxia. And you will see inconsistency, but it's throughout all these tasks, through connected speech, through repetitive speech, in isolated words and short phrases, etc. You can also see some differences in diadochokinetic tasks. For example, if you have a child with CAS go pa 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 pa, they might do it slower, pa 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 pa, or even pa pa, pa, but it'll typically be more even. A child with ataxic dysarthria might go pa 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 pa. Now it's not that black and white. Children vary in severity in ataxic dysarthria as well as in apraxia of speech. So looking at any one context, pa 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 pa, won't necessarily be discriminative. But another thing you can think of is that the children with childhood apraxia will do better if they only have to repeat one syllable versus 2 or 3. So they'll have an easier time with pa 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 than if you have them go pada 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 or padaka padaka padaka. Children with ataxic dysarthria would be more likely, again all of this is relative, more likely to have trouble on all 3 contexts. Children with childhood apraxia will likely have gross motor problems, sometimes called global apraxia, but they won't have an ataxic gait. You know, that wide stance kind of lumbering gait. Whereas children with ataxic dysarthria would be more likely to have other ataxic symptoms, such as the ataxic gait, intention tremor, and general ataxia. So when we are trying to distinguish childhood apraxia from other types of speech sound disorders, not necessarily just ataxic dysarthria, there are a number of different terms that we use in our different classification systems. Examples include phonologic impairment, inconsistent speech sound disorder, articulation delay or articulation disorder, residual articulation impairment, and there are a number of articles that have very nicely described taxonomies or classification systems, and different people use different systems. In motor speech disorders, typically we use the terms childhood apraxia of speech and dysarthria. Now, when we're, again, thinking about distinguishing CAS from other types of speech disorders, I've put this schematic view up on your slides here to show that we can think about speech disorders thinking through language, speech, and voice. And if you look under language, we have language delay, specific language impairment. But when we get down to the bottom, we have phonologic impairment. And we put that there because phonology really is a linguistic process. So you have this phonologic impairment under language. However, we know that phonologic impairment is characterized, or we hear it, as an articulation problem. If you look at that arrow, we see that phonologic impairment is represented by an articulation problem. If we look under the speech, under articulation, we see apraxia and dysarthria. And the circle around that is just to show that we consider these to be different than just an artic problem, that these have a motor speech processing impairment. And under that, of course, is stuttering, and many people have talked about stuttering in terms of motor speech as well. Now, this is a fascinating area to talk about. We don't have time in this video to do that, but there are a number of references that talk about stuttering related to their motor speech performance. We will not be talking at all about voice or cleft palate today. I think it's important to always talk to parents about what's really going on with the nature of the speech problem of their child. And one way that I've talked to parents about that is providing them a very basic model of speech processing. So on this next slide, you see on the input, we have sensory input, which is both auditory, visual, tactile, which leads to perception of that input, which leads to the generation of some kind of output. Again, this is very, very basic. When we think about output, we have linguistic processing going on, including verbal formulation, word retrieval, phonologic mapping. And then that linguistic input has to somehow be translated to a code that will result in actual movement so the listener can hear acoustic output, right? So we've been talking about this motor planning and programming. That involves then, once the movement specification is done, the child, or adult for that matter, has to retrieve and activate that motor plan, which then results in the actual execution of the movement. So using a very simple, basic model like this can be helpful to parents to help them understand where in this model their child might be having difficulty. So in this next slide, you can see that we've also put down the idea of this model in terms of more what has to happen. So we have ideation being first. So the child has to have an idea of what they want to say, right? They have to have the intent to communicate. And communicative intent is a cognitive process. If they're going to convey that intent, they have to use some sort of language. That is, they have to retrieve a symbol. For speech, it's going to be a word. They have to do the phonologic mapping for that word. And if they're going to use more than one word, they have to do the syntactic and grammatic encoding. And those are all linguistic processes. Again, if we're talking about speech, movement has to happen to create the acoustic signal. And that means that motor planning or programming, that is the specification of the range of motion, the strength, the speed, the force, the amount of muscle contraction, has to happen, which leads to the actual output, the acoustic output, which is the execution phase. So we can put that actual communicative disorder into the model as well, and you see that on this next slide. So if there's a problem with ideation or the intent to communicate, we say that child has a pragmatic language deficit, and that usually indicates a child who's somewhere on the spectrum and doesn't yet have either joint attention or the ability to point to what they want, that sort of thing. In that case, we're not worried yet about childhood apraxia of speech or even a speech sound disorder. At that point, we're worried about establishing communicative intent, joint attention. So we won't be talking about that level of processing deficit today. Then, though, the child has to take that communicative intent, and if they're going to talk, they're going to retrieve the word, do the syntactic and grammatical encoding, and do the phonologic mapping, all of which is linguistic. And if there's a problem there, in terms of a speech sound disorder, we usually say that child has phonologic delay or impairment. Or if we're thinking about language, we might say they have a language delay or language impairment. The next level of the model was this motor planning and programming, this movement specification. There's a problem there. We use the term childhood apraxia of speech. And if there's a problem in the execution of movement, we explain to the parent that this term is dysarthria. And I'll sometimes circle whatever their child's having problems with. And typically it's going to be more than one area. And I'll talk to the parent about how one might influence the other. And most importantly, follow it with, what am I going to do to address these? Where are we going to put most of our effort and why? Talking about the whys is really important. So what I'd like to do next is to actually practice some clinical thinking with respect to identifying characteristics that may represent deficits in phonology versus those that are associated with the label CAS. I'm going to play a video clip of a child who was referred to us at Mayo for assessment of her significant speech sound disorder. And what I'd like you to do at home is to list the characteristics you observe that are associated more with phonologic impairment, and list any characteristics you observe that may be associated more with the characteristics of apraxia of speech, and then list any characteristics you may observe that would be more related to a problem with execution or dysarthria. At the end of the clip, I want you to write, later we're going to talk about diagnostic statements, and right now I just want you to write a little note about, do you think this child has CAS, phonologic impairment, or dysarthria, or which combination, and with what relative contribution? After you watch the clip, I'll come back and talk about it for a little bit as well.
House.
What's this?
Window.
What's that?
Tree.
Okay, let's put him on the side. He's making noise, we can't hear you. Say this one again for me.
Telephone.
Say this one.
Tree.
Okay,
Telephone.
good job.
Cup. Night. Boom. Yeah, bit boon and little boon and bit hot and little hot.
The spoon's a big one, but what's this one?
Cup.
A cup, but what did you say? A big?
A big boon and a little boon and a bit fork and a big and a little fork.
Are these forks or knife? What's that?
Apple.
Okay, who's that?
Monkey. Banana. Tree.
Good, okay.
Zipper. Zipper.
Okay, say it one time.
Zipper.
Whoa, you're thinking about your sounds.
Fiddle.
Okay.
Duck.
What color?
Yellow.
What's the duck say?
Quack. Quack.
Good job. What's that thing?
Creeper.
A sweeper?
Yeah, we have a little one and a big one. But
Oh,
we just bought a red one.
you just bought a red one?
Yeah, and we just did our new red one. We good.
You could do what?
We took date our new one. The new what's not our way. People. We did the art. We good.
Oh, okay.
Swimming.
She's swimming. Good job.
I'm swimming in the outside pool.
You want to swim in the what?
Outside pool.
Oh, in the outside pool?
So the child you just saw was referred to Mayo because of her significant unintelligibility and her slower progress in therapy. She actually came with the diagnosis of CAS. I want you to listen now to a little bit of the introduction to that segment and see if my comments match your decision.
This is a child who does not have childhood apraxia. Her speech sound errors are quite predictable. We call these phonologic errors. She doesn't have inaccurate movements, but is simply using the wrong sounds. Examples from this clip are nipe instead of knife, poon instead of spoon, and outtide pool for outside pool. Note that she is starting to correct her errors. Her vowels, speech rate, melody, and stress patterns are all quite good. This type of speech sound disorder is much more common than childhood apraxia of speech.
Now we'll switch to a sample of dysarthria. Again, the purpose of playing the last clip and this one is to help you notice the differences between children that just have phonologic impairment and those kids who just have dysarthria but don't have any childhood apraxia of speech at all. So as you see on this slide, I'm going to have you listen to this sample and note characteristics that provide evidence for dysarthria. In particular, I want you to look for and listen for decreased respiratory support, weak articulatory contacts, and notice that his voice sounds strained. And he does have some spasticity, but I really think that the strain in his voice is more due to the effort required due to a significantly decreased respiratory support. So I want you to be thinking about all of those things as you watch this next video clip.
I live in a blue house. She has a big chest. The chief has a broken leg. Don't go too near to the water. We want to Colorado for a vacation. Sounded like to yesterday. The big dog ran upstairs. Mom is a good cook.
So we've been talking about characteristics of CAS and how to distinguish kids that have childhood apraxia from kids who have more phonologic impairment and children that have dysarthria. Let's talk more and specifically now about how we might do that. And this slide shows you an example of an apraxia of speech protocol that you might use for children. The first thing you see on this is the language sample, which may be done with free play or structured play. And earlier we said that this allows you to make observations regarding phonemic and phonetic inventories, as well as to make observations of apraxic characteristics. You've seen this before, and we talked about each of these in a little detail. This is review leading up to our discussion of the motor speech exam. We then said we might do, if the child's able to name pictures, a test of articulation or phonology in order to evaluate their phonologic skill. We talked about doing a structural functional exam and an examination for oral nonverbal apraxia. And now I want to talk more specifically about the motor speech exam. As I said, this is probably the most important tool in my kit when I'm trying to decide whether or not and to what degree this child might have characteristics of apraxia of speech. So the motor speech exam allows the clinician to observe speech production across utterances that vary systematically in length and phonetic complexity. And for children with apraxia of speech, I also want to vary systematically the vowel content and syllable shape. By eliciting these very particular responses from the child, I am allowing myself to make observations of those behaviors that we associate with CAS, distortions, timing errors, dysprosody, inconsistency, across these hierarchically organized words or short phrases. However, today I also want to make the argument for dynamic assessment, especially for use in motor speech disorders in children, and especially in disambiguating those kids that have at least some component of childhood apraxia contributing to their speech sound disorder. So what is dynamic assessment? Well, it involves a process in which cueing is provided to facilitate performance. That helps us observe emerging skill, as well as often we can observe characteristics that we don't see in spontaneous production. It contrasts with static assessment, which is typical of most of the standardized tests we use, in that in which case those tests look at the child's well-established skills that are measured after a single response and with no cueing or assistance from the examiner. A dynamic motor speech exam offers some advantages, not only in differentiating motor speech impairment in children, but also allows us to see things we don't see in static assessment. For example, with dynamic assessment, we're encouraging the child to look at us, we're providing cues, which allows the child to attempt things that maybe they wouldn't attempt if they didn't have any support. And that's very helpful. For example, if I say a word and the child's attempting to imitate the movement gesture for that word, and I'm not providing any cueing, I just say, tell me, baby. The child is likely to do just what he typically might do, papa, perhaps. But if I'm saying, watch me, we're going to go, baby. Or I provide some tactile cues as support. I slow it down. Maybe even we do it simultaneously. That child might put forth more effort toward producing the accurate movement gesture. And certainly we might see behaviors such as groping that we wouldn't see if he just said it as if he was saying it spontaneously. Without that cueing, children sometimes don't provide that kind of effort or even attention. They've been here before. They've failed before. They don't want to do this again. At least in the tertiary center where I was, most of these kids have been in therapy, and they walk in the door and here I'm asking them to do something they've done many times before with failure after failure after failure. But with dynamic assessment, even with just a little support, I'm consistently surprised at the degree to which the kids will try harder to do things they've never done before. Now, in the case of evaluating children that we think might have some childhood apraxia, we have the opportunity to observe. Remember, we said assessment is just making observations about particular characteristics that we associate with one label or another, right? So in differentiating children that have maybe at least some component of childhood apraxia, a motor speech exam, especially a dynamic motor speech exam, allows us the opportunity to evaluate those characteristics that might be associated with that label, such as groping, such as inconsistency across trials as cueing occurs, such as segmentation of syllables, which may occur only when they're really trying to be more accurate with the segmental movement gesture, or if they're trying to say an unfamiliar or a new to them word that's bisyllable or multisyllable. So dynamic assessment offers that little bit of support that helps the child feel confident enough to at least attempt imitation. And that's all you need, is to get them to make your observations as they attempt to imitate your very carefully selected stimuli on the motor speech exam. So, what is the rationale for a dynamic motor speech exam? Well, first, besides providing insight into the nature of the child's problem, the cueing used in dynamic assessment has the potential to facilitate judgments of severity and prognosis. I can't tell you how important that is. I once did a little survey for myself where people were always asking me, well, what kinds of questions do parents ask you? And I thought, well, I kind of know that, but I wonder what's real. So I just started jotting them down for quite some time, probably close to a year. And I just put them in categories. And when I have an audience, I always like to say, what do you think the most important one was? And people always say, when will my child talk? But it was actually more specific than that. The most important or frequent, the most frequent question asked was, will my child talk by kindergarten? Well, often we have to say, well, we don't know. But I never say that anymore because I usually do know. And I think, well, keep in mind, you have to practice a while before you feel confident about that. And that's just normal. That's in any profession. It's like pattern recognition. The more you see, the more confident you feel about that. But dynamic assessment can help you in that. If a child consistently needs a whole lot of cueing in order to make any improvement in the movement accuracy, or never produces it accurately in spite of all your cueing, it's logical to think of his problem as more severe. Certainly you know that at least the initial training is going to take longer. And the prognosis for rapid improvement is going to be more guarded. So by looking at how much cueing it takes and what type of cues it takes, you can make better decisions about severity and certainly have more realistic discussions with parents about prognosis. The other important thing about these judgments of severity is in a little bit we're going to be talking about the principles of motor learning. And I'm going to be telling you that a big part of making decisions about how to implement those principles depends on the severity of the praxis problem. So knowing or having a good sense of how severe this is going to help you implement these principles of motor learning with the greatest efficiency. For example, children with more severe praxis for speech usually need a much smaller stimulus set size, and we'll talk about why that is, and then it will gradually increase. We know that the more severe the child, maybe the more blocked practice we need at first, although we're going to move to more random practice as soon as we can. And we know that if the impairment in motor planning, processing, is more severe, we're going to provide very specific feedback early on, and then gradually decrease the specificity and the immediacy and the frequency with which we provide that feedback. So the way we implement these principles of motor learning depends on how severe the motor programming problem is. We also have a lot of help with treatment planning if we use dynamic assessment. The types of cueing that proved helpful in the assessment strategy, in the dynamic assessment, are identified, and therefore you can start implementing them right away in treatment. But also looking at the responses across utterances helps you with your initial stimulus selection. For example, you're going to identify specific vowels that are quite distorted across co-articulatory contexts and really choose those in different syllable shapes as your initial target. We'll be talking about how to do that a little bit in this talk, and we'll have a lot of practice with that in the more advanced on-site sessions that we'll be having. I think this idea of early stimulus selection has a lot of impact on how efficient and successful early therapy is. Now that is extremely important because you want to have the child trust you and trust this process, and you want the parent to trust you and trust this process. And rapid early improvement is a good way to help make that happen. So we can consider a motor speech examination that's dynamic in the context of a new test that will be out sometime in 2018 called the Dynamic Evaluation of Motor Speech Skill. This is a test that I developed with a colleague, Rebecca McCauley, because we felt there was no current standardized, although not normed, test that allowed us to use dynamic assessment with the purpose of distinguishing children that were for which the label apraxia of speech or childhood apraxia of speech was appropriate. So the motivation for the DEMSS came from this need for something more structured with the more severe children, even nonverbal children. We needed a motor speech exam that we could design to elicit attempts at imitation for a simple hierarchy of utterances. Remember, this is for severe children. That would allow the clinician to judge variables as to their presence or absence, and especially as to their frequency and severity, that are most consistent with current views of characteristics associated with deficits in praxis. So it allowed us the opportunity to observe what the child did with cueing, and then we could say, okay, do we see any characteristics that are frequently associated with the label CAS? So we examined 4 parameters that were noted in the ASHA position statement on childhood apraxia and in our own clinical work as being most reflective of difficulty with praxis. So the parameters were movement accuracy, vowel error, vowel distortions, consistency over repeated trials, and prosodic error. So those were the 4 things. They're each measured separately. In the advanced workshop, we're actually going to be playing part of the training tape so that you get practice in listening to vowel distortions of different levels of severity, because we found when we were doing our reliability testing that we weren't very well trained in identifying vowel distortions and noticing whether they were quite severe or mild, and as well as prosodic error. So in the advanced course on site, we'll also get some practice in listening for lexical stress errors, but also listening for segmentation and equal stress. As I said, each of these parameters is judged separately. Prosody and vowel errors are judged on the first try at the word, whereas the others are judged after all the cueing. The test also uses a multidimensional scoring system to examine and judge responses to levels of cueing. And that helps us, again, to determine severity and therefore prognosis. But as this slide shows, you don't have to use the DEMSS. What I'm really trying to get at today is that this idea of dynamic assessment is important, even if you do it idiosyncratically for each child you see. You can devise your own dynamic motor speech exam. It might be as short as 5 utterances. You just want the chance to try to get the child to imitate something you say and provide cueing to see their response to that cueing and to see what characteristics might emerge as you work to elicit these utterances. So you would take the child who comes to you, choose a hierarchy of syllable shapes. I always use real words. I don't suppose you would have to. And you choose the syllable shape. Are you going to do CV, VC, CVC, reduplicated syllables, maybe some of each? But you also want to make sure that you sample a variety of different vowels, especially vowels you may not have heard yet or that you've heard distorted, in different co-articulatory contexts, because that gives you a better chance to make the best decisions in terms of choosing your initial stimuli. You say it, have the child watch you while you say it, they repeat it, and then you provide whatever cueing as a clinician that you think is appropriate or helpful. That's certainly up to you. In the DEMSS, that cueing is also left up to the clinician. We make suggestions, but we don't want to provide the opportunity for you to be technicians. The hard part of being an SLP is that we are clinicians. We have to use our clinical thinking in every step of the way. So we want to have the clinician decide what's the best cue for that child at this moment in time. So you provide that cueing as necessary, and then you may choose to just score in a binary way, or you may choose to score in a more multidimensional way. As I said, in the DEMSS, we use a combination of approaches. So we use binary, that is a 0 for no and a 1 for yes, for consistency and for prosody. So prosody is either right or wrong, consistency is either there or not. For vowels, we use a 3-point system. 2 if it's right and correct and we're sure. 0 if it's incorrect and we're sure. And a 1 if the vowel is, if we have to say to ourselves, was that right? And we found this was the way we got the best reliability. And then overall accuracy is done in a larger multidimensional scoring system. So we're not going to take time to go over how to do the DEMSS today, but the point is to tell you that you can make up any system that you want that makes sense to you. Also in the DEMSS, we provide places to note or tally things that aren't scored in that multidimensional system, such as voicing errors and that kind of thing. Now, there is additional evidence in this next slide that has been used in research to provide additional evidence for childhood apraxia of speech. And these were many of the characteristics that we talked about earlier today. Difficulty achieving the articulatory configurations and making accurate movement gestures through the syllable, groping, intrusive schwa, slow rate, trial and error behavior, distorted substitutions, equal stress or lexical stress errors, segmentation, and increased difficulty with multisyllabic words. Now, this list is a little bit bigger because it was designed to also try to disambiguate with kids who are a little older and not so severe some characteristics of CAS. And on the next slide, you see where these observations have been used in several research studies to provide evidence that the children we were studying really had apraxia of speech. They can be helpful in our clinical work, too. We're going to move into treatment here pretty soon, but we have to make a few comments about how do we go from assessment into treatment. And we know that we've done all this work that we've just been talking about, providing appropriate tasks so that we can make these observations that either match a clinical label or not. We come to our differential diagnosis, we write a diagnostic statement, we make initial recommendations, and then we determine the initial speech therapy goals. So, assessment to treatment. You come to a differential diagnosis, you write a diagnostic statement, you make your initial recommendations, and then within those recommendations will be specific goals for speech improvement. Now, this is what we all do. Maybe we don't think about it in these terms, but that's typically what we do when we see a child. So I'm going to be talking now a little bit and more later about this idea that I brought up earlier about being clinicians. Later you're going to see me talk about a number of different techniques, approaches, methods for therapy in a childhood apraxia. We'll be focusing most specifically on dynamic temporal and tactile cueing, but I'll also be talking about prompt and rest and other kinds of interventions. Here's the point I want to make right now. You know, being a good clinician isn't being good at DDTC or being good at prompt or being good at rest. That's part of it. What makes you a good clinician are all those clinical decisions you have to make as you implement whatever treatment. A method, a treatment, is just a well-described set of cues. That's really all they are. You still have to decide what stimuli are you going to use. You still have to decide how are you going to organize this practice. You have to decide how much feedback, when, why. That's being a clinician. The method is just a little part of it. Remember that doing therapy for childhood apraxia isn't teaching this child every movement they'll ever have to do, every syllable shape they'll ever have to do. Of course not. what we're doing is using these stimuli that are very carefully selected as a vehicle to practice the processing they're not very efficient with. That's all it is. The stimuli are just a vehicle for practice, and the goal is to improve motor planning and programming processing so that movement is more accurate, that it becomes more habituated, that it becomes more natural and requires less conscious control. So the method's not the end all. We spend a lot of time learning methods. I've been asked many, many times to just talk about DTTC, but I think it's much more important to talk about the clinical decisions you have to make as you implement DTTC, or the clinical decisions you have to make as you implement prompt or rest or any treatment. So as we move ahead, I want you to be thinking about that. You're a clinician. You're going to make all of these decisions have to be made by you for each individual child at any particular point in time. What we do is hard. This is what makes it hard. But it's also what makes our therapy most efficient and most efficacious, not the method. So, we've come to a differential diagnosis. Now what do we have to do? Well, we're charged with communicating that to people, aren't we? We have to, at Mayo, my job was to communicate the results of my assessment, the differential diagnosis, to the referring physician and the family, the parents. If you're in a private practice, you will probably have to make a diagnostic statement along with your more detailed report to whoever referred the child to you, as well as to the family. If you're in the public schools, you have the IEP, you have lots of paperwork to fill out. And where you don't always, in the public schools, the IEP paperwork doesn't lend itself well to this kind of diagnostic statement, but once a year you write these longer reports, in which case the diagnostic statement is very important and would be very appropriate to include. I think these statements are important because they need to reflect our clinical thinking. The clinical thinking that went into determining the relative contribution of phonologic impairment versus motor planning impairment, and including any execution impairment, dysarthria, that may be there. But I also think they have to illustrate our clinical thinking in terms of illustrating the overlapping nature of the presenting deficits. I think they should include some statement of severity and prognosis. Those of you coming to the on-site advanced workshop will get actual practice in writing diagnostic statements, but I want to give you at least a couple of examples here. On this slide I also put practice in writing diagnostic statements is practice in clinical thinking. I can't stress that enough. Teaching graduate students, they don't have very much experience, so it's harder for them to do this sort of thing. But I would always encourage them to write a diagnostic statement just to practice the kind of clinical thinking that they'll have to do when they start seeing a bigger variety of speech disordered children. So here's an example of a diagnostic statement. This is a 5-year-old male who is exhibiting low average receptive language skills, severe impairment in expressive language, and a severe impairment in speech acquisition due primarily to difficulty with planning and programming movement gestures for speech production. And then parenthetically, I put childhood apraxia of speech. There's no frank evidence for dysarthria. He is pragmatically and socially appropriate, focuses attention well, and attempts all tasks. Now, it doesn't have to include just those things, and it certainly doesn't have to be said as I said it. But what's important to note is that we provide information about what impairment we noticed and what's going well. A second diagnostic statement has a little more specificity, and this is more typical of what I might do. This child exhibits a moderate phonologic impairment characterized by fronting and consistent typical substitution errors for later developing sounds. In addition, he exhibits a slightly slower rate, more difficulty with multisyllabic words, occasional segmentation, and occasional vowel distortions, providing evidence for a mild contribution of difficulty with praxis for speech, parentheses, mild CAS, close paren. There's no evidence for dysarthria. There is no evidence for receptive or expressive language delay or cognitive impairment. So those are two very different diagnostic statements. Each diagnostic statement might look and sound quite different depending on the child. The idea is to include in these diagnostic statements your clinical thinking about the relative contribution of these impairments leading to his overall communicative disorder. That helps you sort of set the stage for your discussion with parents about your initial recommendations, your initial speech goals, and why you're making those decisions. This ends this segment. We'll come back and begin talking more specifically about the treatment of childhood apraxia of speech.